Yeah.
Well, welcome some folks already to the, I guess, first of the year T32 Journal Club. Um, Anna Rose had the brilliant idea of sort of making us speak each other's language. And in that realm, we will have sort of the preclinical basic science postdocs and fellows and students try to give clinical, or give, not try, will give clinical papers. And we'll see if our clinical colleagues can get into the weeds with some of the molecular biology and basic science. And so I think it's going to be a fun semester to sort of experience this. Today's presenter is Dr. Amelia Dunn. She is a postdoctoral fellow in my lab. She started last January, so was literally live in the lab for maybe 2 or 3 months, and has spent most of her time in quarantine, but has been really amazingly productive during that time. Um, She's actually working on a project related to animal models of neonatal opiate withdrawal, and so the selection of her paper today is quite relevant. She comes from another opioid lab, Mary Jean Creek, where she got her PhD at Rockefeller, again, just about a year ago. So welcome everyone, and we look forward to your comments, and any clinical comments will be helpful for us to think about in terms also of our animal models. So without further ado, Amy.
Awesome.
Thank you so much.
Okay, I'm going to share my screen here. That should work. Everybody can see it, yes?
Yes.
Okay,
Yes.
fantastic. All right, so I am presenting this paper from 2017, this buprenorphine treatment for the treatment of neonatal abstinence syndrome. And like Julie and Anna Rose were saying, I am a basic science person, very used to working with mice, and so I'm going to try to do my best to present this clinical paper to you all. Please feel free to interject with questions or comments, and then I have, I guess, some kind of things that I thought about when I was reading the paper at the end we can talk about if we want to and if we have time. Also, when I'm presenting, I don't have a clock anywhere, so if I'm running out of time, somebody please let me know also. Okay. So just a little bit of background about neonatal abstinence syndrome, also called neonatal opioid withdrawal syndrome. NOWS is what we've been calling it in the lab when it's specifically opioids. But it is a set of symptoms that occur in neonates when they're exposed to drugs in utero. And so the symptoms range from things like high-pitched crying and seizures, sort of neurological symptoms, sleep deprivation, to some more somatic symptoms like sweating, hypertension, a lot of GI issues, things like diarrhea, vomiting, all sorts of things. And some of them are associated with adult withdrawal as well from opioids or other drugs, and some of them are kind of specific to this neonatal condition. And so I think we've had a couple different talks in last year's set of T32 talks about neonatal opioid withdrawal, specifically in terms of its occurrence in our area. You can imagine that as the opioid epidemic in general rapidly increased over the past decade, that mothers who were pregnant, the prevalence of opioid use with them also increased, and so therefore the incidence of neonatal opioid withdrawal increased correspondingly. And so this is just a paper from a local newspaper showing the incidence of drug exposure in babies in southeastern Pennsylvania. And you can see in some areas it is incredibly high. So Kensington, for example, 5.1% of all live births, or 8% here in Chester County, or I guess Chester in Delaware. But so this is obviously affects a surprisingly large proportion of babies in our area and in the US in general. So the way that neonatal opioid withdrawal or neonatal abstinence syndrome is treated is first behaviorally, and in 1/3 of cases this is sufficient. So things like decreasing the amount of stimulation in the room, in-room sleeping, so having the baby sleep in the same room as the mother. Breastfeeding actually is one of the behavioral interventions that was found to be really, really effective. And even mothers that are continuing on things like methadone maintenance therapy are really encouraged to breastfeed. And then frequent high-calorie feedings also really help alleviate the different symptoms of neonatal abstinence syndrome. But in those other 2/3 of cases, pharmacotherapy is required. And so you can imagine that just like we treat adult withdrawal by supplementing with opioids, they do the same thing for neonatal abstinence syndrome. So babies are supplemented. 80% of pharmacotherapy is morphine. Other opioids are also used, which I'll talk a little bit about later. And then if the morphine isn't sufficient to treat the symptoms, then supplemental phenobarbital is often used as well. So the point of this paper is to examine the use of a different opioid instead of morphine for the treatment of neonatal abstinence syndrome. And specifically, they're looking at the use of buprenorphine. So buprenorphine is another mu opioid receptor agonist, but it is partial agonist. So it has a little bit of different pharmacodynamic characteristics than morphine. So in this graph, I'm just showing an example of percent effect on the y-axis and the dose of the drug on the x-axis. And so morphine is a full agonist. So its maximum, it exerts a 100% maximal effect at the receptor. Whereas buprenorphine is a partial agonist. And so no matter how high you get in the dose, it has a ceiling on, I think it's actually maybe more like 30-something%. I'm not entirely sure, depending on which outcome you're looking at. But it isn't all the way up to 100. It's a partial effect. And so because it has this lower maximal effect, it might have lower side effect profiles, such as less respiratory depression when it's used in adults. For maintenance therapy, the thought is that it might have lower potential for abuse. And then in addition to this, buprenorphine also has a longer half-life than morphine does. So yeah, buprenorphine is used in adults to manage withdrawal symptoms. It's also used in adults as maintenance therapy. And so this paper is asking the question of how does buprenorphine compare with morphine specifically for neonatal abstinence syndrome? And can we use it to treat that disease? So here in this paper specifically, they're looking at the primary outcome is the length of treatment for neonatal abstinence syndrome. Their secondary endpoints are things like the length of the hospital stay and then the use of that supplemental phenobarbital treatment. And then they have some other endpoints they use. Things that I was interested in specifically were their exploratory endpoints, which were respiratory rate and weight gain. And so that's kind of what the questions that the paper is looking to answer. So they recruited their patients at Thomas Jefferson University. And they recruited patients with neonatal abstinence syndrome and then stratified those by their feeding status. So like I was saying, breastfeeding is actually known to be really good and helpful for neonatal abstinence syndrome symptoms. And so they wanted to make sure that they controlled all of their data for breastfeeding. So here you can see the characteristics of the infants that they recruited. They were all full-term infants, so they excluded any preterm infants that were born before, I think, 37 weeks. 37 weeks. They had similar birth weights, sex ratios, and then they divided the breastfeeding subgroups evenly as well. They looked at some other infant characteristics that are often associated with neonatal abstinence syndrome. So they looked at things like head circumference, and other characteristics like that. And then in the mothers, they wanted to, or their original plan was to stratify by which maintenance therapy drug the mothers were on. But so this is the opioid that the babies are exposed to when they're in utero. And they wanted to separate by the use of methadone versus the use of buprenorphine, but then it turned out that they had very few mothers who were using buprenorphine, so they actually totally excluded that from their analysis, and they didn't take this difference in maintenance therapy into account, since the overwhelming majority of the mothers that were in the study were on methadone. So the babies are recruited to the study. They are scored for the severity of their neonatal abstinence syndrome, and then babies that have a certain score, hit a certain threshold, are given a pharmacotherapy that triggers. It's a score of over 12 or a sum of 3 scores over 24 triggers pharmacotherapy. And then once the baby needs pharmacotherapy, then they divide those into a morphine or a buprenorphine group, and then stratified by breastfeeding. So they use a this kind of modified score. There's a bunch of different scoring systems, it looks like, for scoring neonatal abstinence syndrome. This one is a little bit more simplified than some of the others because it makes it easier for nurses to do. They do it every 4 hours. And so you can see they're looking for all of those symptoms we saw in that little baby slide in the beginning. So things like excessive crying, issues with sleeping, digestion issues, general like failure to thrive, irritability, things like that. And so any single score over 12 or a sum of 3 scores over 24 triggers the need for a pharmacotherapy. So then they give the pharmacotherapy to the baby, and then they continue to adjust the treatment as the baby either gets better or if the symptoms get worse. So they increase the doses by, it was either 10 or 20%, depending on the part of the trial they were in. And then once the score reached stability, if it was low enough, then they started to wean the baby off the opioids until they were no longer on any drug at all. They were examined for another 48 hours after that, and then they were allowed to leave the hospital. So that's how they kind of collect that data on how long the treatment is. So the length of the treatment is directly related to how bad the symptoms of neonatal abstinence syndrome are. Okay. And so these are their statistical methods that they're using. So again, the primary endpoint is the length of treatment, and they use a stratified Van Elteren test. These are the clinical new words for me as a basic scientist, all of these statistical tests. Their secondary endpoints were the length of hospital stay and the use of the supplemental phenobarbital. And then their exploratory endpoints were this respiratory rate and weight gain. Okay, so before I get into the results, does anybody have any questions so far on the kind of background and setup of the study?
Hi.
Oh, hi.
We haven't met yet before. I'm Liz. I put a couple questions in the chat.
I actually can't see the chat because I'm sharing the screen. Sorry.
I'm also new to this field. So one of my questions was, how often is now diagnosed in opiate-addicted mothers? Like, what percentage of the offspring show the phenotype? That was like one question I had. And then about sex differences, this like background stuff. I don't know if you want to get into it now. And then another question I had, just in terms of study design, like, are the nurses blind to the maternal condition was one question I had. And then is there like are there control infants that they're also scoring? I just don't know how these types of studies are built.
So that's a great question about the prevalence in mothers on opioids, what the prevalence of NOWs is in their babies. And I actually don't know that, but I can look into it, and I'll check when I'm sharing the screen. I can't look at the paper at the same time, but I'll check. That's a good question. I think it's a pretty high percentage. I don't know about sex differences either in this study. It's, pretty even. And these are the babies that needed pharmacotherapy. So these were the babies that had reached that high enough threshold that they needed a pharmacotherapy. Sorry, and then remind me your last question. Oh, the nurses, so the nurses were blinded.
Like whoever's assessing the score, like whoever's scoring, do they actually know whether the mother was addicted or not, or on opiates?
Yes. So all of the babies in this study had neonatal abstinence syndrome symptoms. There are no drug-naive babies.
There are no drug-naive babies. Okay.
Right. Yeah. And I think that this scoring system is based off of, many years of clinical research showing that these scores reliably can differentiate babies that are going through have this neonatal abstinence syndrome. So I think that's the scoring system is used. It's used to, determine the amount of drug they're getting. But they give buprenorphine or placebo because the drugs are given different routes. So the buprenorphine is sublingual and the morphine is oral. So the nurses are giving buprenorphine or placebo every 8 hours, and then morphine or placebo every 4 hours. So they're blinded to the treatment, if that makes sense.
Yeah, that's cool. Gotcha. Thanks.
Yeah, if anybody else has questions, and put them in the chat. I can't see the chat, so you have to turn your mic on. Sorry. So getting into a little bit of their results. So the final protocol analysis included 58 infants. So they had 121 that had the informed consent, but then only 63 actually needed pharmacotherapy. So those other 58 were fine with just the behavioral interventions. And so then these 63 underwent randomization, and then a couple were withdrawn. And so then they end with this 30 buprenorphine babies, and then 28 that were given morphine. So for the primary outcome, they did find that buprenorphine led to a shorter duration of treatment. So here you can see in this table, they're looking at these buprenorphine and morphine babies, and so they're including some of these that were withdrawn. So their numbers here, they have the 63 that were randomized in total. And they did the analysis both ways, both with the 58 and the 63, and they didn't find any difference. And so these are the same statistics regardless. And so when they stratify them by bottle feeding versus breastfeeding, and they find that the median duration of treatment is 15 days for the babies in the buprenorphine group and 28 days for the babies in the morphine group. And so you can see that same data just in a different representation here. So duration of treatment is on the y-axis, and the drug and the type of feeding is on the x-axis. And you can see that both comparing bottle feeding groups and breastfeeding groups, that the morphine has a longer duration of treatment, and buprenorphine appears to give a shorter duration of treatment for these babies.
And what's like a normal duration of treatment without any drugs? Or
that's just like a drug naive, how long?
Yeah, because we don't have a drug naive group here. And I'm also wondering, is that like unethical to include that group? Like if these babies do need pharmacological therapy, is that unethical? And that's why we don't have a control group for this study?
I see. You're saying if the baby had neonatal abstinence syndrome and didn't get pharmacotherapy? Yeah, I don't think that they could include that group, since I think the standard of care is morphine. And so I don't think that they can include. I don't know how long that would be. I also don't know, and I thought you were asking, which I also don't know, is how long the standard stay is for a drug naive baby in the hospital. This seems very long for the babies to be in there for a month. The duration of treatment to be, and this is the duration of treatment. Next, they look at hospital stay, and that's up to 40 days, which seems very long. So.
But Amy, if I could just comment on Daryl's question. So this whole idea, is it ethical not to give treatment? And a couple of years ago, there was like a lot of articles, even in the Inquirer, nursing staff, and this idea of that there's a group of people that don't think these babies should be getting any drugs at all. They call them, fondly, they call them the baby huggers. So that, they say, just all treatment and, cuddling, and they have these volunteers that come in because they need to be constantly held and whatnot. But you're right that overall then the duration for their stay is much longer than for any pharmacologic treatment.
So I guess the definition of what the standard of care is, I assume that different hospitals set that for themselves. So maybe if this had been done at a different hospital, they could have included that group if they consider the standard of care to just be those behavioral interventions, and they don't consider opioid treatment to be necessary. So maybe that's not such a hard and fast line in terms of what must be included or what can't be included. In their secondary endpoints, they looked at this duration of hospital stay, which obviously is very related to the duration of treatment. And so here you can see that secondary outcome here, the median length of hospital stay, which again is only 21 days for the buprenorphine, and then 33 days for morphine. And so here again is that same graphical representation of that data, just with the length of hospital stay on the y-axis. And you can again see that in both groups. The bottle feeding and breastfeeding, morphine has a higher length of hospital stay, a longer length of hospital stay than the buprenorphine. But there were.
Sorry, maybe you said this. So they're discharged once on those same assessments. They're at like a typical. There's like a score that refers to typical, or like do they have to get all the way to totally drug naive infant, or are they just looking for improvement?
It's an absolute cutoff. It's a score. I think it was 3 consecutive scores with a total less than 12. It says in the paper what the actual number is, but there's a hard and fast cutoff.
And that's like trying to get them to appear on those assessments the way that a baby born to a drug naive mother would assess.
I assume yes. Or at least the symptoms are enough that they can be managed with those behavioral interventions. So they stop the pharmacotherapy once they reach that score threshold. Then they're observed for 48 hours, and they can be given, a rescue dose after that, and then that extends on their stay after that. So it's not that the hospital stay is always going to be exactly 2 days longer than the duration of treatment. They could trigger additional pharmacotherapy that they might need to, if that makes sense. They did still find that was significant here. It did look like the ranges obviously are still, or at least the upper end of the range is still the same. So, there were still, the 70 days seems insane. And both some babies treated with morphine and with buprenorphine had to stay in the hospital for 70 days. Okay, and then their last secondary endpoint was looking at the use of the supplementary phenobarbital. And so I don't think I went into that detail when I was talking about the methods, but basically if they there was a maximum dose of both the drugs. And so if they hit that maximum dose, then it triggered the use of this supplementary phenobarbital. And so there wasn't they noted very few infants in either group needed this supplementary phenobarbital, only 5 and 7 in each group. And then there was no significant difference here in the use of that supplementary drug. Okay, and then they do talk a teeny bit in the paper about their these exploratory outcomes. So respiratory depression is really important. That's how opioid overdoses occur, is that in addition to opioids causing analgesia and euphoria and all these effects, they also slow down breathing, and that's how overdoses occur. And so that's obviously the one major reason why babies need to stay in the hospital during this opioid treatment, is that they need to be observed for their neonatal opioid syndrome, but also for respiratory depression caused by these opioids. And the thought with buprenorphine is that if it is a partial agonist, maybe it won't cause as much respiratory depression. Maybe that will hit a ceiling effect, and that would be really positive for treatment. And so they did find that in the paper, they didn't give the exact numbers, but they did say that buprenorphine increased respiration. So they had less respiratory depression than morphine by 4.4 breaths per minute. Which it had a very high confidence interval, but they did find that to be significant. And they did say that all of these respiratory rates were in the normal range, however. So none of the babies who were given morphine were having serious respiratory depression at all. These were all within normal, but it did look like buprenorphine helped in this symptom specifically. And then they also looked at this reduction in weight from birth. So the difference in weight at 7 days compared to weight at birth, and these babies are losing weight because they're sick. And so they found that morphine actually had less reduction in weight from birth, which is a lot of negatives, but that means that's a good thing. So in this case, the buprenorphine actually caused more weight loss, which was also significant. But they did say that there was no difference at all when they looked 14, 21, and 28 days after birth. So that might doesn't pan out in the long term. Okay. And then finally, they looked at the adverse events. They had 2 serious adverse events, one in each group, but really no significant differences in the adverse events between the groups. So that is a good thing and expected since they're, similar mechanisms and they think that they're getting a kind of similar clinical effect in the doses. Okay, so based on these findings, then I guess the central question that they're really trying to ask is like, should buprenorphine be used to treat a neonatal abstinence syndrome? Which I think is a hard conclusion to draw, obviously, based off of just 163 infant study. It's a relatively small sample size. Also, this was only done at one center, so it doesn't necessarily generalize to a larger population. They also excluded some really key populations. So they excluded preterm infants, which many babies born with neonatal abstinence syndrome are preterm. They also specifically excluded infants that were exposed to benzodiazepines. And so the use of benzodiazepines during pregnancy is shown to make neonatal abstinence syndrome much worse. And so there's, really key treatment populations like this that they didn't include. So I think it's difficult, obviously difficult to generalize the conclusions. However, they did show that even with this small sample size, they still found pretty significant findings that it's more effective in reducing the duration of treatment. 13 days is, 2 full weeks for a newborn baby is a lot. And then I just still think that finding of less respiratory depression is significant. Also coupled with the fact, they mentioned this in the paper, that buprenorphine has a longer half-life than morphine does. And so they gave buprenorphine every 8 hours as opposed to the morphine every 4 hours. And so the fact that there's less of a safety concern with respiratory depression and that there's a longer interval between doses means that buprenorphine could have potential for outpatient treatment, which obviously would be great. I think that, nobody wants to be in the hospital for 70 days after giving birth. So being able to do that treatment at home, I'm sure, would be really beneficial for patients. So yeah, I think that these are kind of the main findings of their paper. And so maybe I'll stop and see if people have thoughts or comments before moving on to some kind of thoughts and comments that I had.
I had another question. So once they start the treatment, they continue the behavioral treatment. So that's then contemporaneous. They
the things like the breastfeeding and the in-room sleeping, and that they actually didn't really talk about the use of that. But I assume, I guess the breastfeeding is stratified by the groups, but things like the decreased stimulation and in-room sleeping and frequent feedings and things I don't know if they specifically, I assume that they kept doing those. Again, I think that it would be ethically a little questionable if they didn't, but.
Yeah, right. And the moms are withdrawing from opiates? Is their status?
They're on maintenance therapy.
You said that. They're on maintenance therapy. Okay.
Actually, Amy, I had a question about that, and maybe some of the clinical folks. So this study was only, a few years ago, 2017, and in the Philadelphia population, we hear so much about everybody being on Suboxone and buprenorphine, but I was surprised how many more moms were on methadone. So what's the more common medication-assisted therapy, I guess? Is it methadone or is it buprenorphine these days? And that's more for the general group.
So one of the reasons why if this trial were done at Jefferson, Jefferson has the Family Center, which is the one place in Philadelphia where pregnant women go to get methadone. So if I identify a pregnant lady and she wants to be on methadone, I'm going to send her to the Family Center at Jefferson. Although methadone is the treatment of choice for pregnant women, there are a significant number of women treated with buprenorphine. And so overall, though, buprenorphine, there's probably more people on buprenorphine than there are on methadone in the world.
Thanks.
Yeah, that's good to know. And interesting, because that was actually, I guess, one of the things that I was wondering is because this is so, if so many of these moms were on methadone and not buprenorphine, then why isn't methadone used to treat the neonatal abstinence syndrome? Because, did somebody?
I can give you some information on that, which is also an important part of our history, because the person who really pioneered the treatment of the neonatal abstinence syndrome is a pediatrician who is the one who started the program that Kyle just mentioned at Jefferson. Her name is Loretta Finnegan, and she started this program. First of all, they were using paregoric, which is tincturated opium, and also phenobarbital, as you mentioned earlier. But it became a very important thing. First of all, methadone was always very controversial, and in a way, I mean, what I would tell people back in those days is that if you can give cuddling to a baby and that does the trick as far as reducing the symptoms, that's fine. But very often it's not enough. But then people worried so much about the long-acting effects of methadone. So we were all reviewing grant applications like mad, during the 70s, and even doing long-term follow-ups, because what about the milestones of the baby as, at age they walk and talk and so forth? And people said, methadone would delay all of that. Well, it never really did. But the big problem, and this goes with the understanding the issues around clinical research, the big problem with the grant applications was that the women took a lot more things than just heroin, and later cocaine became a major issue, and smoking. Smoking has turned out to be really bad for fetuses. I think that the buprenorphine is a great idea, but we're going to keep trying one after another. And the early work with buprenorphine, or rather with paregoric, was in the 70s, the early 70s. So, a lot has happened since then, and it illustrates a lot of the differences between basic research, when you can just order a few more rats or mice, and clinical research where the subjects do anything they want and don't tell you about it necessarily, and so this is a perfect illustration of how it helps to have an animal model, and you can combine things in different ways, and use the animal model to direct your clinical research.
Yeah, definitely. I think kind of to that point, I was exactly digging to try and see kind of what clinical studies there were directly comparing different opioids. And there aren't many, and the ones that exist have very small ends also. And for reference, at this moment, we're doing a mouse study, and we have 100 mice in each group. So yeah, I think that and that we have very, very fine control over what drugs they take and how much and when. So I do think that this is a really good instance where we can use the basic research to kind of fill in some holes maybe, and then also use hopefully, this was really helpful for me. Again, I'm doing one of these experiments right now. So this is really helpful for me to kind of try and think about how it can make our mouse model more translational and match closer to the clinical condition also, which was really, really helpful. And so, yeah, so I was looking at, some of these papers that were reviewed in this review is from 2014. So there have been a few studies since, like the one that we're looking at now, for example. But most of them are comparing things like that tincture of opium you were talking about to morphine, or morphine to methadone. And then there was these series of papers by this group that wrote this paper looking at comparing buprenorphine to different drugs, both to this tincture of opium and to morphine itself. And so it looked like, they did look at the use of methadone and didn't find a difference. These ones with the stars are the only ones that were significant. And so I thought that was definitely interesting. There are also a bunch of studies that I didn't look too closely into, but would be interesting, comparing the use of methadone as a maintenance therapy versus buprenorphine as a maintenance therapy, and then the outcomes on the infants as well. So, does buprenorphine maintenance use lead to less severe neonatal abstinence syndrome outcomes? And it looked like there were maybe a couple studies that suggested that it might be some less severe symptoms. Others, at least one other study that suggested there wasn't really a difference. So I think that a lot of those clinical questions are just, really difficult to answer with precision, because, you just don't, you're missing at least some part of the picture. So.
Are there longitudinal studies on the infants, with or without treatment?
Yeah. So that's something that I think that specifically is a question that we're really interested in getting into more with the animal models, because it is so difficult to study in humans. So there definitely are a bunch of studies trying to look at longitudinal outcomes. So there's a decent amount of studies that say that there are cognitive deficits, maybe, especially there was a big study done in Australia showing that, like, by 7th grade, children who had neonatal abstinence syndrome as babies fell behind in school. But then there are also studies suggesting that there are no differences. So it's, I think, the same kind of mixed bag that's very difficult to parse because of, is opioid use during pregnancy concomitant with any other sort of hardships in life, maybe, or specific home conditions or stress. There's just lots of different things that are difficult to pinpoint what is the specific effects of the opioid exposure or the specific effects of the withdrawal. So it suffers from the same difficulties. So I think that another thing that would be really interesting to study, and that we can look at more closely in mice or rats, is the questions of, what other drugs could we use to treat neonatal abstinence syndrome? So could we use other opioids, for example? So there's the mu-opioid receptor, which is, the target of morphine and buprenorphine and everything. But then there's also the kappa opioid receptor and the delta opioid receptor, that are also both at least lead to analgesia and then have a whole host of other effects. So, the kappa actually has negative reward, kind of aversive effects. The delta opioid receptor has really potent effects in mood. And delta antagonists help with seizures, which is also a symptom of neonatal abstinence syndrome. So I think there's a lot of interesting kind of opioid pharmacology that's going on right now, that obviously it might be difficult to test in humans, but could be easier to test in animals. Related to that, there's a lot of work going on right now looking at biased agonists, and specifically biased mu-opioid receptor agonists. So this idea that, when an agonist binds to a receptor, so when morphine binds to the mu-opioid receptor, it's a GPCR, so it signals through G proteins. It also signals through arrestin and leads to a whole host of signaling cascades and a bunch of different downstream responses, including euphoria, respiratory depression, and analgesia. But the idea of a biased agonist is that when it binds to its receptor, it only activates a subset of those signaling responses, theoretically only leading to a subset of those behaviors. So there's some clinical trials going on right now looking at mu-opioid receptor agonists for pain treatment that might have that are G protein biased. They only activate G proteins but not beta arrestin, and can they more effectively lead to analgesia without the respiratory depression, for example? So as far as I know, none of these have been tested in neonatal abstinence syndrome, certainly. But depending on how these, I don't know, one clinical trial that I'm aware of definitely the drug was rejected by the FDA because it didn't seem like it was any better than morphine. But there are lots of others And this is definitely a really active area of research. So that was also something that came to mind as how these other types of opioids might be useful. And then finally, this paper definitely helped me to think a lot about my own mouse experiments, and specifically trying to think about how translational really are our models, and can we do anything to make them better. So, we in human, this is neonatal opioid withdrawal, same thing as neonatal abstinence syndrome here. In humans, there's, especially during maintenance therapy, there's opioid exposure during all 3 trimesters. The baby is born, and then they experience a prolonged period of withdrawal, as we've seen, leading to hospital stays of up to 70 days. In our mouse model that we're currently using of neonatal opioid withdrawal, we have a mouse exposed to opioids through gestation. Then the mouse is born, and when the mouse is born, it's developmentally equivalent to the second trimester in humans. And so we keep giving the mouse morphine for the first 2 weeks of life to kind of mimic those 3 trimesters. And then on the 15th day, we stop giving opioids and we measure withdrawal. And so we measure withdrawal just 24 hours after the last morphine dose. We look at things like ultrasonic vocalizations. We look at pain sensitivity. We look at the somatic signs of withdrawal, things like put them in a beaker and look at whether they try to climb the walls or jump. And so I thought that was really useful to be able to compare what the different measurements that we look at with this clinical scoring. And, we look at things like excessive crying are similar to the ultrasonic vocalizations that we measure. We weigh them every day. There are some of these somatic signs that we look at, but I think that this really led me to think that there are definitely some other things we could look at too. So there's certainly some easy things like sleep and feeding changes that seem to be really prevalent in neonatal abstinence syndrome in humans. That could be really easy to look at in the mice. And also if we should be doing any sort of additional monitoring past 24 hours. So again, obviously the duration of treatment for human babies is very long, and this goes on for a while. And so maybe that should be something that we're looking at more in our mouse models too. So, overall, I think that this was an interesting paper, hopefully has some really good clinical implications. And I thought that this exercise in general was really useful for me as a basic scientist to try and think about the clinical counterpart to the work that we're doing. So thank you. Any questions or comments?
Terrific presentation, Amy. I had a sort of a free association sort of question here that is parallel to some of the other things that we've been talking about. It's not really a critique of this article per se, because I think they said they stratified on breastfeeding, and most of the moms seemed to give it up. They didn't really persist in the breastfeeding. But I had this sort of vague memory of people talking about breastfeeding being associated with, number one, sort of very positive feelings on the part of the mom. I wondered if they had any endogenous opioid significance in any way, in terms of whether or not that would be something that is part of the soothing that goes on. So this is just a parallel question. And then the other question is just sort of more mechanistic. When people are breastfeeding, if they're on methadone, are they transmitting, and how much are they transmitting small amounts of opioids to the baby to, quote unquote, treat the abstinence?
I think that was the original hypothesis, is that it was just transfer of drug. But I think they found that there's actually only a very small amount of drug that's actually transmitted. There definitely is some, but there is something about the breastfeeding itself. And so, whether that's some sort of like oxytocin or endogenous endorphin kind of thing, I don't think the mechanism is really known. But I think it's, definitely.
I was curious. I'm just curious about that. And I didn't know about the percent that was, I assume there was some transfer across the from the milk to the bloodstream, but I didn't really know. So it's interesting to think about. But they controlled for it. And I think they didn't talk too much about why they controlled for it, but I'm guessing it has something to do with some of those earlier thoughts about either controlling for transfer or other non-specific things.
And I think that there's actually been, that's one of the few behavioral interventions there have been like very specific clinical studies showing that breastfeeding does help. So I think that that's a known variable. So I think that also is important for them to control for.
Yep, absolutely. By the way, the other thing is just sort of, oh, go ahead.
No, please.
Well, this is probably a naive question, something that I missed in reading the procedures, but even though it talks about buprenorphine versus placebo and morphine versus placebo and a corresponding placebo, in the graphs it always just refers to one versus the other, and I didn't really see in the statistics that they were subtracting from placebo, and I wasn't sure how that would work during the protocol. Like, basically, I was thinking of it before I read about the references to placebo. It was going to be a standard, assigning them to standard care with morphine in the usual way that they do it versus buprenorphine. So how did the placebo play into this? Sorry to be obtuse.
No, I had to go back. I was actually thinking the same thing, and I had to go back and look for it also. But I think what it is the buprenorphine is sublingual and the morphine is oral. And so in order to blind it, basically at every drug time point, they had to give something sublingually and something orally. And so, so the babies in the buprenorphine group could get sublingual buprenorphine and oral placebo, and then the babies in the morphine group could get.
Oh, I see. So really,
so
it's just
two treatment groups.
It's for the purpose of essentially blinding the people who are administering it, or if the baby would take notice. But it wasn't really like something. I was thinking that's double blind, double dummy. That's why. But so I read that and I was thinking, but wait a minute, it's really just basically, that's why.
Yeah.
Thanks.
Yeah, I was looking for placebo in the graphs too. I had to go back and check.
Thinking, no, it's not that. It's not that. It's just so that it can maintain the blind. Yep.
Mm-hmm. Amelia, in your preclinical experiments, do you have any way to control? I mean, the dams are going to lactate, the pups are going to breastfeed, right? So what are your thoughts about that?
We cross foster.
You did?
So cool. Yeah. So we move them to drug naive moms after they're born. And then we continue to give them controlled injections of the drug for the 2 weeks afterwards. So
But the non-morphine component of the breastfeeding, I wonder, if there's any way there might be something interesting there. I mean, what if oxytocin is therapeutic? What if you gave it to them intranasally and that helped with the syndrome? So if there was a way for you to get at that
they still breastfeed though.
Right, but in the human population, not all the moms breastfeed. And so is there any way to sort of get at that? I mean, I was thinking a different thought, which was, are there any other classes of drugs that could relieve this syndrome in infants besides opiates? So that was like a separate question. But then when we were talking just now about the breastfeeding, if there is, a neurochemical component to that, like oxytocin, serotonin, I mean, there's a lot that gets released in neonates, especially during breastfeeding. I'm sure you'll come up with something clever.
Yeah, that would be really interesting. I don't know.
I don't know little tiny mouse bottles. I don't know.
Yeah, I don't know what the mechanics are of rearing pups without breastfeeding.
No, but it's interesting. I mean, even with the foster versus the biological dam could be a slightly different, oxytocin component. I don't know. I mean, it's it's different biology. They're not voles, obviously, but I don't know. I mean, there might be something you'll figure out to model that component, because breastfeeding likely has a therapeutic benefit for these infants.
And I think that's what they found in humans too. So I think that would be. But then I think you get to the kind of downside of preclinical research, which is like, obviously some of those social interactions are really difficult. We're doing kind of interesting social behaviors with the adult pups once they've grown up. But there's only so many dimensions of social behavior you can get with mice. So
maybe but in the litter, they don't all get equal access to the dam's milk. And I wonder if you stratified by that, maybe you see something. I mean, I don't know. There could be something interesting there, since these data sort of suggest that that's a therapeutic benefit.
Yeah. And I do think that maybe looking at more feeding behavior or more even like GI type of things could be really, really interesting moving forward. So I think that definitely is something
have access to that. Totally.
Yeah.
That's exciting. I'm also a Rockefeller alum, by the way.
Oh yeah, the Heinz lab, right?
Yeah, thank you.
Nice
Going
to meet
back
you.
to the going back to the placebo things, I thought it was super interesting that the buprenorphine was made up in simple syrup and 30% ethanol, and then the placebo didn't have ethanol. So, like in preclinical stuff, I feel like you would get ripped for that because um, you're not really controlling for the ethanol effect. Is that something specific to the clinical world,
I think
would you say?
if somebody who does clinical work wants to chime in, I noticed that too, and especially because they aren't insignificant amounts of liquid. It's 30% ethanol, but then they give up to like they were in the mills. So that seems for a newborn baby that maybe that might be a decent amount of sublingual ethanol to give them. Yeah, and I was curious to why they didn't put that in the placebo too, but I don't know.
In question,
Maybe,
I don't know either.
yeah.
Yeah.
I don't know if
Okay.
maybe it could have something to do with what Daryl was mentioning earlier, that like if we know that giving ethanol to newborn babies is bad, is it unethical to give additional ethanol to them? You know, like if the placebo babies aren't already getting alcohol, maybe it's unethical to give them additional alcohol. I don't know. That's one guess, I guess.
Have you ever had the chance to meet Loretta Finnegan in the flesh?
Oh, I haven't read lots of papers with her name on it though.
She's a very
She's a
good
very,
tennis
she's a
player.
very, she's a very colorful individual. She plays a very strong role in the College on Problems of Drug Dependence. In fact, was the, I guess, executive secretary the last few years, but has been president in the past. She has more colored shoes and colored handbags. She laughs. She's famous for this. In addition to her wonderful papers, she's got a lot of matching shoes and bags in all sorts of colors. She's quite colorful. And her hair, my hair is assisted by CVS. Hers is ultra assisted. She has a lot more hair than I do, and it's a lot redder. So you'll be able to see her at some point. Hopefully, we'll get to introduce you to her at some point if we ever get out of this pandemic and ever have other human conferences where we have people talking to people, not just on Zooms and Blue Jeans. You'll get to meet her. And she has a long, as Chuck said, long and colorful history of this field that is even more colorful than her accessories.
And I just want you to know she's a very good doubles tennis player. Those of you who like tennis can come to the CPDD meetings every June or so. And
Well, not this June, but yeah,
Yeah.
they've already, Chuck, they've already made it virtual. So, last year was virtual. So when we ever get one again, you'll be able to meet some people face to face. But maybe we can have Loretta attend one of our Zooms or virtuals so that she actually could meet some of the trainees. I think she would really enjoy that.
yeah, she would. I'm sure she would love to do that.
And that's by way of a segue to next week. It's not a journal club. It's actually a seminar on February 1st with Dr. Yuri Persitsky. And I've been waiting for his talk title to be finalized to send out an ad, but I'll just give a bit of a plug for it now. He's a person who works in the preclinical domain at Temple University, has a lot of funding, recently a large grant. He looks and works at the intersection of HIV, neuroinflammation, and substance exposure, because it's animals, and ranging from alcohol to opioids. And he's done work with cannabinoids and has some new ideas on therapeutics. So he is in a really interesting domain, relevant to so many of the things that we're doing, both in the preclinical work and in the P30. So he will be next Monday at 3:00. And if I can get the final talk title, I'll send out a picture of him today and a reminder, but I'll give an advance notice to those of you who are on the call today. And I'm really glad that we had a good active discussion. It was a really nice translational blend. Julie, it's really fun. This was a really good idea. Not because of where it originated, but just because it seems to be working. Anyway.
Thumbs up. Great job, Amy and Anna Rose for coming up with the idea. I think it'll be fun.
Can't take any credit or blame for that presentation. It was wonderful. So it was great.